ما في صوت.
ما في صوت الحين؟
قبل شوي تتكلم راح الصوت انقطع.
شوف دكتور قدام اسمك فيه إشارة نازلة مرة.
اوكي.
هذا دليل على أن اتصال الإنترنت ضعيف.
هذا الغريب انه بالسيك، يعني المفروض يكون افضل من الواي فاي، مش كده؟ طيب خلينا استغنى عن المايك واتكلم بالتليفون باللابتوب مباشرة. طيب كيف الصوت الان؟ اوضح شويه؟
نعم الحين ما فيها أي مشكلة.
خلاص، يمكن تكون في مشكله في المايك، احتمال الهيدسيت. In this lecture, we're going to cover the clinical features and the important clinical presentation of dysphagia. We're going to talk about dysphagia. Dysphagia simply, as we'll see in the few minutes in this presentation, is some difficulty in swallowing. But before I start my presentation, I would like just to ask you some few questions regarding the basic science, some basic information which are necessary to understand this condition. So, I would like to ask you about the two important concepts regarding dysphagia. The first one is the swallowing. Swallowing. I would like to ask you about the phases of swallowing, if you can remember that from your basic science lectures. Can you tell me, please, about the phases of swallowing?
أنا أذكر دكتور إنه ينقطع النفس لفترة يعني بسيطة عشان يحصل ليبيجلوتيس، لسان المزمار، عشان التراكية.
Yes. These are the events which happen in each phase, but my question is basically about the phases. What are the phases initially of swallowing?
We have oral phase, the first one.
Yes. Yes.
Then pharyngeal, then esophageal.
Yes, very good. These are the three important phases of swallowing. Can you mention what happened in the pharyngeal phase of swallowing?
Actually, regarding
Yes.
في موفمنت دكتور حق المسلز حق الفارنكس اللي هو بارستاليسيس موفمنت.
Peristalsis, no, peristalsis is mainly in the esophageal phase, but now we are talking about the pharyngeal phase. What are the events which take place in the pharyngeal phase of swallowing?
the pharynx will go up and the epiglottis will close the airway.
Okay.
And
yes.
the muscles of the soft palate will close the airway also, and the bolus will go down.
Yes, actually, the soft palate will move. This is part of the oral phase. Yes, in the pharyngeal phase, when the food reaches the pharynx, then what you get here, you get a coordinated reflex. A coordinated reflex. Events are coordinated here by means of a center responsible for that, which lies in the brainstem, in the medulla oblongata. So what happens actually is that the larynx move upwards and outwards, and this is basically to move the food away from the airway, from the trachea. As you mentioned, then the epiglottis closes the tracheal orifice, and then what you get after that, you get what? Relaxation of the muscle which guards the upper esophageal sphincter. Can you mention what is the name of the muscle which guards the upper esophageal sphincter?
في دكتور ستايلوفارينجياس وفي سالينجيوفارينجياس وفي بلاتوفارينجياس.
The only one which you did not mention is the muscle which guard the upper esophageal sphincter. Actually, this muscle is named cricopharyngeus. Cricopharyngeus muscle. This is the muscle which guards the upper opening of the esophagus. It's all the time is kept contracted. It relaxes only when food arrives into into the pharynx. When the food arrives into the pharynx, you get some stretch, and this stretch will stimulate stretch receptors, which send impulses to the medulla oblongata, and then eventually get dilatation of this muscle, and then food passes into the esophagus. Okay, so these are the most important events which take place during the pharyngeal phase. Okay, I have another question for you, but I will leave it for later, which will be about peristalsis, the second most important basic concept behind dysphagia. So what is dysphagia? If we consider the definition of dysphagia, basically dysphagia is difficulty in swallowing. If you want to define it in more details, we usually say it is a partial or complete loss of the ability to swallow, either partial or complete loss of the ability to swallow. It's classified actually based on the level of the pathology which results into dysphagia. Dysphagia does not have a single cause. Dysphagia is a clinical condition which can be caused by a spectrum of conditions actually. These conditions might lie in the upper part of the GI, literally in the pharynx, or lower down in the esophagus. Based on where the pathology lies, which causes dysphagia, we classify dysphagia into pharyngeal and esophageal. In pharyngeal dysphagia, the cause usually lies at the level of the pharynx. The pathology which results into dysphagia lies at the level of the pharynx, while in esophageal dysphagia, the pathology or the cause lies in the body of the esophagus. Okay, so this is a very basic and useful classification for the causes of dysphagia. It will make it easy for you to recall or determine the cause of dysphagia. Okay, so here now, so far we talked about the definition of dysphagia, and we talked about how do you classify dysphagia based on the level of the pathology. So now, to make it easy for you to understand the clinical features of each entity, then we're going to consider pharyngeal dysphagia alone, and then we'll talk after that about esophageal dysphagia, because causes actually, or the etiology differs. The etiology differs depending on the level of the pathology or which dysphagia the patient is having. Let us first of all start by pharyngeal dysphagia. In pharyngeal dysphagia, the basic disorder here is a problem in the swallowing reflex, a problem in the swallowing reflex or in the swallowing mechanism. Swallowing mechanism is abnormal. And characteristically, what do you get here? That when the food arrives into the oropharynx, the cricopharyngeus muscle fails to relax. The cricopharyngeus muscle fails to relax, and that means what? That means the food now cannot pass from the oropharynx into the esophagus. Okay, and the question here, where will it go? The question here, where the food will go? If the food cannot pass down, you are trying to swallow, the food cannot pass down into the esophagus. It's accumulating now in the oropharynx. So where will it go?
It will push against the trachea, the closed epiglottis.
Not the trachea. The food should not go into the trachea. The food should not go to the trachea. Yes, Faisal? Yes, Faisal?
Yes, it will push against the.
Yes. Now the food. Yes. Look at this. Part of the slide. Now the food is coming here in the oropharynx. This is the cricopharyngeus muscle. This muscle should relax in order to allow the food to pass into the esophagus here. This is the cricopharyngeus muscle, and this is the esophagus. Now the problem that this muscle fails to relax because of disordered swallowing reflex, and this can happen sometimes due to medical conditions like Parkinson's disease, pulpar palsy, neurological disease, muscular disease, and so on. Okay, so because of failure of this muscle to relax, food now cannot pass into the esophagus. So where does it go? It actually push against the lateral wall of the pharynx. This is the lateral wall of the pharynx. Okay, it push against that wall, and in this wall there is an area of weakness. There is an area of weakness, which lies between the middle fibers and the lowermost fibers of the cricopharyngeus. You see this area? This area is an area of weakness, okay? Between the middle fibers and the lowermost fibers of the cricopharyngeus. And then what do you get? You get herniation or outpouching of the wall like that, okay? And every time the patient eat and eat and eat, the food is stored here. The food instead of going downwards, it is stored here in this pouch. And what do you get? The pouch enlarges progressively. The pouch enlarges after that progressively until it hangs down like this. When it hangs down like this, it can also press on the lateral wall of the esophagus, making dysphagia worse, worse, okay? This area anatomically, do you have any idea about what do you call this area anatomically? This area of weakness? Do you have any idea what do you call this area? What do you call this area of the area of weakness in the lateral wall of the esophagus? Yes, very good, Saif. This area is known as Killian's triangle. This area is known as Killian's triangle or Killian's dehiscence. Dehiscence means weakness. So the foot will push through this area of dehiscence or this area of weakness, resulting in the formation of this pouch. And this pouch eventually, when it becomes large enough, it appears in the neck as a neck lump, and usually this happens on the left side more than the right side. So eventually this lump will be felt in the neck as a neck lump, as I mentioned, mainly on the left side rather than the right side. Is it clear now how does this pharyngeal pouch or Zinker diverticulum happens?
Yes, it's clear. Thank you.
Now, having mentioned the pathophysiology, yes, for safe, said that this is the cricopharyngeus muscle, and which guards the upper end of the esophagus. This muscle should relax in order to allow the food to pass here. It relaxes actually as part of the swallowing reflex. If there is any disorder, abnormality in this reflex, then this muscle will not relax, will fail to relax, and then food cannot pass downwards. If it cannot pass downwards, then it will accumulate in the oropharynx. It will push on the lateral wall of the pharynx, in which you get an area of dehiscence, as you mentioned. This is known as the Killian's triangle. And what happens? You get outpouching, because this area is weak. It will be pushed to the outside, and eventually it progressive, actually steadily, and every time the patient eats, and then eventually you get this large lump, which can be felt actually in the neck, posterior triangle, most likely on the left side rather than the right side. So this is the pathophysiology. Now, what are the clinical features? What are the clinical features? These are the most important clinical features, as you can see in this slide. We have got regurgitation, rumination, halitosis, and on examination you get a neck lump, as I mentioned. Let us review quickly what are these. Yes, the food will when the patient eat the food, instead of passing down to the esophagus, the food will be stored where? Will be stored in this pouch. Okay, and the patient can actually, or the food actually can regurgitate back into the mouth. The food can regurgitate back from the mouth, from this pouch into the mouth. This is regurgitation. Regurgitation, by the way, is different from vomiting. Regurgitation is different from vomiting. Vomiting is the expulsion of the gastric contents. Expulsion of the gastric contents, while regurgitation usually does not, the contents or the vomiters is not coming from the stomach. It's coming from the level above the stomach. Okay, so the patient can regurgitate. This is the first clinical feature, and this regurgitation, by the way, can happen during night, and the patient might awake coughing, might awake coughing because of some aspiration, might awake coughing because of some aspiration. Usually they tend to regurgitate and aspirate, which could be a bit serious during sleep. This frequent regurgitation and aspiration can also result into frequent chest infections, can result into frequent chest infections, and eventually it can even lead to chronic bronchitis or even a lung abscess So usually a Zinker's diverticulum or a pharyngeal pouch can be complicated by respiratory disease due to aspiration, regurgitation and aspiration, particularly during night. Okay, so that was about regurgitation. Now the second one is rumination. Rumination is actually a symptom which is happening in the setting of pharyngeal pouch, and it's quite clear to another phenomena which happens in animals. You know what happens in animals? Animals, they can regurgitate the meal that they had it ingested long time after the time of ingestion. What do you call this, please, in animals? What do you call this process in animals? Do you have any idea?
اللي يسمونها الاجترار.
يسموها الاجترار. الاجترار is typically rumination. Electrar is typically rumination. Because the food does not pass into the stomach, the food actually, instead of passing into the stomach, the food is stored where? It is stored in the pouch. So the patient, for example, having his breakfast at 10 o'clock, he can get the content of the meal that he had at that time, maybe 2 or 3 hours after that time, back into his mouth. And this is because the food is stored in the pouch, and it can be returned back into the mouth. So they develop a very characteristic symptom, which is quite to happens in animals, and this is known as rumination. Halitosis actually is the symptom of having a bad smell coming from the mouth. Symptom of having bad smell coming from the mouth. Why do you think those patients they develop this symptom of having bad smell coming from the mouth? The patient can tell you about that, or sometimes a family member can tell you that. We recognize, for example, a bad smell coming from the mouth of the patient. Yes, and what happens secondary to this stagnation? Actually, you get fermentation, not infection, but you get fermentation. Fermentation, you know, this is a process which can be induced by bacteria, and usually fermentation is associated with bad odor. Sometimes associated with bad odor, and this explains why they get this halitosis, because food is stored here in the pouch, and then you get fermentation, and secondary to this fermentation, you get a bad odor coming from the patient mouth. So again, halitosis is an important symptom of a pharyngeal pouch. When the pouch becomes large enough, then the pouch can appear as a lump in the neck. Usually this happens in the posterior triangle of the neck, and most of the time it happens on the left side more than on the right side. Mostly on the left side rather than the right side. Okay, because there are many neck lumps that can be encountered during examination of the neck. To characterize pharyngeal pouch, usually this lies where in the posterior triangle, mostly on the left rather than the right side. So these are the most important clinical features of a pharyngeal pouch. First of all, the patient will have difficulty in swallowing, and the level is most likely lies at the mouth, okay, or at the level of the pharynx. The difficulty usually in the level of the mouth, and then the patient will describe. Yes, this is just a fact. Yeah, this is just a fact that it can happen, by the way, on both sides, right and left, but it tends to happen on the left side more than the right side. The most important features are regurgitation, rumination, halitosis, and then the appearance of nigglum in the posterior triangle. By the way, just I will go back to mention one information that I did not mention here. That how did you notice that the patient have got a pharyngeal dysphagia? How did you notice that the patient have got a pharyngeal rather than esophageal dysphagia? Clinically, how do you
ممكن ماتش دكتور في الفارنكس
By palpation the posterior triangle on the left side, we feel a mass.
No, I'm talking about pharyngeal dysphagia. Basically, pharyngeal dysphagia. I went back to a slide that we have passed through just to clarify one thing. First of all, we need to know whether the patient have got a pharyngeal dysphagia or esophageal dysphagia. How would you clinically recognize that?
الفارنجيال دكتور بيكون فيها بريذنج يعني لس او يعني ما راح يكون فيه good breathing.
Yes, actually you can do two things. First of all, you can ask the patient directly, where do you feel the difficulty? If he will tell you, for example, that I had difficulty in swallowing, then you can ask him directly, where do you feel that difficulty during the swallowing, and the patient might point to the area of the upper part of the neck, and this will clearly tell you that this dysphagia is actually lies where so this patient will be having pharyngitis. Why? Or whereas if he has an esophageal dysphagia, he will point to area where along the course of the esophagus in the chest, along the course of the esophagus, he might point to the area of the sternum, a little bit below, or even below. Okay, so if the patient pointed to the pharynx or pointed to the upper part of the neck or pointed to the throat, for you this dysphagia is most likely pharyngeal dysphagia. If he pointed to any point across the thoracic course of the esophagus, then this dysphagia is mainly an esophageal dysphagia. And as I have mentioned previously, that this classification is very important because it will tell you about the underlying cause. One of the most important job for you as a physician in the hospital is to find out what is the cause of dysphagia so that you can treat the condition. Okay, so if you want to differentiate, then you ask the patient, where do you feel the difficulty? Sometimes the patient can tell you that I have difficulty in the food, getting the food leaving the mouth. If he says something like that, then this is most likely again esophageal dysphagia. So at the very beginning of your clinical evaluation of those patients, to find out the underlying cause, try to find out whether the dysphagia is pharyngeal or esophageal. Okay. The second causative factor or etiology of pharyngeal dysphagia is a post-cricoid cancer, and this is a malignant disease or cancer which happens at the level of the cricoid cartilage, the cricoid cartilage. And may I ask you, what do you think that will be the most important differences between in the clinical feature, I mean between pharyngeal pouch and a post-cricoid cancer? Both of them will have pharyngeal dysphagia. Both of them will point to the pharynx or to the throat. What do you think the clinical picture will differ between a pharyngeal pouch and a post-cricoid cancer?
Maybe there will not be a regurgitation, doctor.
Actually, both of them they can regurgitate. Both of them they can regurgitate. But remember that pharyngeal pouch is a benign condition, while this is cancer. This is malignancy.
Doctor, will be not mobile mass. When you feel it, it will be not mobile mass.
You might not feel a mass actually, because those patients can die very early before the cancer appear as a palpable lump. But think of other things. think of other differences in the clinical presentation between a benign condition and a malignant disease.
ممكن دكتور يكون عنده مشاكل في الريسبيراتوري.
ممكن hoarseness in the sound.
Yes, I will come to this. But first of all, what do you think about the onset and the progression of the disease? What do you think about the onset and progression of dysphagia?
Sudden.
Yeah,
Chronic.
yeah, it will be much faster, no? The onset and the progression will be much faster than in pharyngeal pouch, because this is malignancy. Here you got a tumor, malignant tumor, which grows maybe very quickly. Okay, so the disease will progress in very short time. Okay, and as you have also mentioned, you will get features of local infiltration. You can get features of local infiltration of surrounding structures. Okay, for example, if the tumor spread to involve the recurrent laryngeal nerve, as you mentioned, the patient can present with what? With hoarseness. Okay, the patient can bleed from his nose, and this is you can get epistaxis. Okay, yes, and you can get also infiltration of the larynx, giving rise to stridor or difficulty in breathing. Okay, so all these features are local infiltrating features characterize cancer wherever in the body, and this is one of these examples. Okay, so I think regarding the clinical feature, you can easily differentiate between post-cricoid cancer and between a pharyngeal pouch based on the onset, progression, and the presence of local infiltrative features or metastatic features. Again, the patient can if you evaluate carefully in the history, you might find an underlying cause, for example, a family history of similar condition, for example, a family history of similar condition or any other predisposing factor, whether genetic or exposure to radiation, for example, and these things which are known to expose patients to malignant transformation. Okay, so these are the most important things that can be mentioned regarding the post-cricoid cancer. There is also a very interesting condition that results into esophageal dysphagia, which is known as WEPS. And by the way, WEPS does not only happen in the pharynx. WEPS can happen in the pharynx, they can happen in the esophagus, or they can happen even lower down in the esophagus, very close to the stomach. When they happen in the esophagus, they result into a very characteristic clinical condition, which is known as Plummer-Vinson syndrome. Plummer-Vinson syndrome, or the second name for this condition is also Patterson-Kelly. It's also Patterson-Kelly. I think you might have heard about this condition in your basic science lectures. Did you? Did you?
We did.
Yes. What yes. You said we did, or we did not?
We did not.
No.
Yeah. Why I've said that, because one of the very characteristic
هذا دكتور مع الأيام يعني
yes, very good. This condition is characterized by iron deficiency anemia. So usually it is mentioned in physiology or in pathology in relation to iron deficiency anemia. Okay, Plummer-Vinson syndrome is a condition which usually happens in females. Usually females are affected more than males, and usually it happens in middle-aged females, around the age of 40 years, in young adults or in adult females. Okay, and they tend to have WEPS. Which act actually like bars, which obstruct the movement of food from the pharynx into the upper part of the esophagus, and the patient will characteristically have the features of iron deficiency anemia. So what symptoms the patient might mention as part of this condition due to anemia?
Pale face, difficulty to swallowing.
No, I mean the symptoms. What are the main symptoms of anemia? Before going to the physical examination.
Get tired early, fatigue.
Yes. Easy fatigability. This is we call it easy fatigability. Yes, easy fatigability is one of the symptoms. Yes, what else? Palpitation.
Dysphagia, Doctor.
The patient can have also palpitation because of this decreased hemoglobin concentration and anemia. He can also get
Short breathing.
short breathing and dyspnea if the condition became very severe. So the important thing here that if you are evaluating a patient who have got dysphagia, particularly if it is pharyngeal dysphagia, then some of your questions has to be devoted to assessment of anemia, particularly if the patient is a lady at the age of 40, because here the possibility of plummer-Wilson syndrome will be very, very likely. So here you have to ask about what? You have to ask about easy fatigability, you have to ask about palpitations, you have to ask about dizziness, as you mentioned, shortness of breath or dyspnea if the condition is severe and so on, okay? And in the examination, you mentioned pallor and cholinekia. You mentioned pallor and cholinekia, okay? So these are the most important clinical features regarding the plummer-Wilson syndrome, okay? There might be other causes of pharyngeal dysphagia, but for summarization, I will just mention these three conditions, which is pharyngeal pouch and post-cricoid cancer and plummer-Wilson syndrome. Okay. Now we have talked about yes.
البلامر وينسون هذا زي اللي هو نفس الاسم حق الاسوفيجيال الويب.
Yes, plummer-Wilson here, the syndrome. This is the name of the disease. Okay, the pathophysiology. Yeah, the pathophysiology. How does dysphagia happen? There are webs, which act like bars, projecting into the esophagus and preventing the food from moving down. Is it clear?
Yes, Dr. Clear.
Yes. So we have talked about pharyngeal dysphagia. Now we will talk about the other entity in relation to dysphagia, which is esophageal dysphagia. Okay. As I have mentioned earlier, basically the patient will tell you that I have the food stucking somewhere along the course of the esophagus. Okay. The patient will point to the chest. For you, this means what? That this dysphagia is mainly esophageal rather than pharyngeal. Okay. So again, in order to be easy for you, able to reach the underlying cause, first of all, try to find whether dysphagia is esophageal or pharyngeal, and at each one of these headings, then there is possible causes. Okay. So let us now move to talk about esophageal dysphagia, and here we have got two important causes for esophageal dysphagia: either a mechanical obstruction. Some conditions can be treated surgically, some conditions can be treated conservatively, and in some cases you can do only palliation. Okay. So as I have mentioned, that your course at this level mainly focuses on the clinical features. I'm not going to go into details of investigations and management. What I need you to know at this level is the clinical feature and the clinical presentation of esophageal dysphagia and pharyngeal dysphagia. When we come to later in the 6th year, we'll talk about the details of the investigations and the management. Okay. So two main causes of esophageal dysphagia: either mechanical obstruction, and here what I mean is for example, a tumor bulging into the human and causing and obstructing the food from moving down into the esophagus, or you get this motility in the body of the esophagus, or motility disorder. Okay, so causes of esophageal dysphagia: either mechanical obstruction or motility disorder. The classical example of mechanical obstruction is esophageal cancer, in which you get a lump or a swelling or a tumor projecting into the lumen of the esophagus and preventing the food from moving downwards. And the classical example of motility disorders is known as achalasia. The classical example is achalasia. Okay. So, as I mentioned here, the problem lies where? In the body of the esophagus. The cause of dysphagia lies in the body of the esophagus. The patient will tell you that the food is stuck somewhere along the course of the esophagus, so he will point to somewhere in the chest. Okay, and these are the important causes. Esophageal cancer as a cause of mechanical obstruction to movement of food downwards. Achalasia as a classical example of motility disorder. Stricture can also be a mechanical factor, and esophagitis or inflammation of the esophagus. So these are the most important causes of esophageal dysphagia. As you can see here, part of these are related to mechanical obstruction, and part of these are related to motility disorder. Before I talk about the clinical features of esophageal dysphagia, I just have one question for you in this figure, which you see in this slide. This is a schematic representation of the swallowing in the esophagus. This is the side of the mouth, and this is the side of the stomach. This patient or individual now is ingesting this bolus of food, which is moving from along the esophagus from the direction of the mouth, and it should reach where? It should reach the stomach. So here we have got a mechanism. And then we have got two chemical substances or neurotransmitters which facilitate movement or progression of this bolus of food down into the esophagus. Actually, this question is about peristalsis. So my question is here to you is, what is this mechanism? What is substance B, and what is substance A? Yes. First of all, what do you call this mechanism? How does you said there is dilatation in the front of the bolus of the hood, and there is food, and there is constriction behind it. How does this happen? How do you get this relaxation? How you get this constriction?
from اللي هو stimulating signals from a biomechanism called peristalsis.
Yeah, yes. The question is about peristalsis, but the question here is, how does peristalsis happen? This is my question.
When it's arrived to the esophageal, there is receptors that send to the mind to receive, like it's
so here, yeah. So here you get the food. What does the bolus of food do? It causes dilatation of the wall of the esophagus. Okay, it's causing a stretching. It's causing a stretching of the wall of the esophagus. This will stimulate what? This will stimulate stretch receptors. This will stimulate stretch receptors which lie where? In the wall of the esophagus. Okay, when these stretch receptors are stimulated, then this will send impulses through which nerve? Through which nerve these impulses will travel?
vagus, doctor.
Through the vagus, yes. Correct, yes. It travels through the vagus to where? To the brain stem. But part of this, the most important, that this, instead of traveling to the vagus, this reflex is coordinated where? Is coordinated locally. It's coordinated locally. So you get stretch of the wall, and then you get stimulation of these receptors, and then you get what? Secondary to this, you get what? Dilatation in the frontal foot of the bolus, and then constriction behind. Okay. What is the substance which causes constriction behind the bolus of foot?
What do you mean by substance, doctor? There is only like a stimulating
neurotransmitter. I mean, a chemical substance or neurotransmitter.
Neurotransmitter, doctor.
Yes. Which one causes constriction behind the bolus of food?
acetylcholine.
Acetylcholine, yes, very good. And what causes dilatation in front of the bolus of food? Which neurotransmitter causes dilatation here?
Anti-acetylcholinesterase.
This is known as nitric oxide, actually. Nitric oxide. Okay. So this is a mechanism, is a stretch reflex. Stretching the wall of the esophagus by means of the bolus of food, resulting in stimulation of stretch receptors in the esophageal wall. And this reflex, by the way, is coordinated within the wall of the esophagus. It does not require the vagus nerve to happen. Okay, it does not require the vagus nerve to happen. Okay, so what is the nervous system or the plexus responsible for coordination of this reflex?
Enteric nervous system, Doctor.
Enteric nervous system. Which part of the enteric nervous system is responsible for coordination of these peristalsis?
Doctor, you mean submucosa and muscularis?
Yes, we have the myenteric. Which is known as the Orbach.
And mesenteric.
Yes, and we have the submucous. The submucous is responsible for mucus secretion and coordination of regulation of secretions, but the myenteric is or the Orbach is responsible for coordination of peristalsis. Okay, and that is what happens actually in achalasia. You get destruction of this Orbach plexus, Orbach plexus. And when you get destruction of this plexus, the patient loses the ability of peristalsis, or he cannot actually exhibit normal peristalsis. And this is the main mechanism of achalasia, actually. Okay. Yes, esophageal cancer, one of the most common causes of esophageal dysphagia. And considering the clinical features of this disease, this is the cancer again, like when we talk about post-cricoid cancer. So the onset is progressive, actually. The onset is progressive. It can happen in very short time in comparison to other benign conditions. So the patient can develop this dysphagia, which can progress over a very short time to complete dysphagia. Start as partial and then it ends as complete dysphagia. And because this is cancer, we expect that the patient to lose weight. This is part of the tumor cachexia, which happen on those patients. And we can also find features of metastasis. The tumor usually metastasizes to the liver, and the patient can develop jaundice, or it can invade or infiltrate the lungs, and the patient can present with hemoptysis. And sometimes the patient develop pneumothorax, pneumothorax if the tumor invaded into the pleura. Okay. Yes. So again, if you are evaluating a patient who have got esophageal dysphagia and you suspect that the patient have an esophageal cancer, then you have to go through the risk factors as part of your evaluation, clinical evaluation of the patient. You have to go through the risk factors, and these which you can see in the slide, these are the most important causes or underlying causes of esophageal cancer. Smoking is one of the most important risk factor for development of esophageal cancer. Alcohol consumption, consumption of smoked food, particularly fish, because in the skin of fish we get a substance which is known as nitrates. And when you cook this food, like putting grilling or putting this skin of fish under direct effect of flames, then this nitrate will be converted into nitrose amino compounds.
يعني ما يصلح شوي يا دكتور؟
Yes, أنا أتكلم عن الشوي نفسه، عن الجريلينج. It can be a risk factor. Because nitrates in the skin of fish will be converted into nitrosamine compounds. Nitrosamine compounds is a non-carcinogen. Is a non-carcinogen for development of of cancer. This is they have noticed that in China, in Japan, because they consume this smoked food heavily, they noticed that the rate of esophageal cancer in those areas was a little bit higher than other areas. And from that, they concluded the association between smoked food and esophageal cancer. Barrett's esophagus. Do you know what's a Barrett's esophagus? What's Barrett's esophagus?
Change in the mucosa.
Yes, this is metaplasia. This is metaplasia in the lower third of the esophagus, which happens due to chronic injury due to acid reflux. Chronic injury to the mucosa of the lower esophagus due to acid reflux. And here, the columnar epithelium, which lines the lower part of the esophagus, which is squamous, will be replaced by columnar epithelium. This is metaplasia, and metaplasia can proceed into dysplasia and then into malignancy or cancer. Genetical factors also play a role, and family history is very important thing to ask for. So, where do you think you should mention this information regarding risk factors? This should be part of the history. This should be part of what? Part of the history and part of the history of present illness. If you are evaluating a patient who has got dysphagia and you think that he might be having an esophageal cancer, then you have to investigate these risk factors or predisposing factors as part of your history of present illness, as part of the history of your present illness. Okay. This is an upper GI endoscopy of a patient. I just wanted to show you how does it appear. The patient is complaining of esophageal dysphagia, and then we did an upper GI endoscopy. What we have seen is a tumor projecting in the luminal esophagus like this, and actually causing obstruction of the foot. However, there's a very characteristic pattern of dysphagia in esophageal cancer. Okay, and here one question for you: what do you think is easy for this patient with this picture to swallow? Is it easier for him to swallow solid diet or
only liquid, doctor? Liquid easier.
Yes, he can. For this patient, he can easily swallow liquids more than solid. Why do you think so?
Because the tumor is obstructing the esophagus.
Yeah, because liquid can pass easily, no? Liquids can pass easily through space. But for solids, because they are unmalleable, they cannot pass easily through here. So characteristically, the pattern of dysphagia in patients with esophageal cancer, that it starts first for solid. Solid. The patient will tell you it was easier for me to swallow solid. To swallow fluid rather than solid diet. Okay. However, when the tumor enlarges, it can eventually obstruct the whole lumen, and at that time it will be difficult for the patient to swallow both solid and fluid. Yes, Abdullah. Yes, Abdullah.
Doctor,
Okay.
I have a question. Is it polyp?
Yes. Ask Abdullah. Ask. Abdullah, I cannot hear you, Abdullah.
يقول دكتور هذه بوليب ولا تختلف؟
هذا تيومر، هذا malignant tumor، هذا cancer. This is the cancer. Yes, معاذ.
دكتور بالنسبة طيب all tumors of esophagus is like malignant or cancer, not benign tumor?
What? Again, please.
All tumor of esophagus cancer, all it's malignant? Like there is no benign tumor?
No, there are. Actually, there are. You can get, for example,
Most common.
you can get a muscular tumor for example, leiomyoma or rhabdomyoma or rhabdomyoma. Okay.
But most of our cases is
cancer is the
cancer.
most common. Yeah, cancer is the most common. Cancer is the most common. Okay. So characteristically regarding the features of the pattern of dysphagia in esophageal cancer, that it starts for solid, and then eventually it can be for solid and for fluid type. Yes, Faisal.
دكتور هل الاسوفيجيال فاريسيس يسبب نفس الاعراض الاسوفيجيال كانسر؟
No, it does not actually cause dysphagia. It rather causes bleeding. It causes bleeding, but it does not cause dysphagia. Okay. Yes, regarding the physical examination, regarding the physical examination of esophageal cancer, actually, no many signs can be seen, and this is basically because the esophagus is deeply seated into the chest, so you cannot feel a tumor actually because of that. However, you can see the features of metastasis in examination. First of all, the patient will appear cachexic, and then you can see the features of metastasis like jaundice, for example, due to liver metastasis. Or you can on chest examination, you can, for example, find features of pneumothorax, and also most importantly, you can get a dilated lymph node, which usually can happen in the left supraclavicular fossa, and this lymph node is known as the Virchow lymph node. And the Virchow lymph node itself is a sign. The Virchow lymph node itself is a sign which is known as the Trozius sign. Okay, I will talk about that a little bit later. So these are the most important points regarding esophageal cancer. And now we will talk about achalasia, which, as I have mentioned, is one of the classical examples of motility disorder in the body of the esophagus. Okay, here the dysphagia, the onset actually will be less sudden and more gradual in comparison to esophageal cancer. That's because that is malignancy actually, and here there is no malignancy, there is not cancer. This happens, as I have mentioned, this happens because of loss of ganglia in the Auerbach plexus in part of the esophagus, loss of ganglia in the body of the esophagus, particularly in the Auerbach plexus, which result into loss of peristalsis, Okay, the patient they will have regurgitation. Actually, in the area in which the Auerbach plexus is lost, you get an area of constriction. There is an area of constriction, so food cannot pass downwards, and the patient can regurgitate. Regurgitation is different from vomiting, and this regurgitation can happen again during night, and the patient can aspirate, and again he can present with features of chronic chest infection. This is one of the presenting features of achalasia. So here, nocturnal cough, the patient awake during night coughing, repeated chest infections, hoarseness of voice due to acid reflux into the throat and causing sore throat. Okay, and there is a typical clinical condition of achalasia that happens in South America, and destruction of the Auerbach plexus is caused by a parasite. This parasite is known as Trypanosoma cruzi. If you heard of that, yes, Trypanosoma cruzi. Trypanosoma cruzi results in destruction of Auerbach plexus, and this disease is known as Chaka's disease. It's known as Chaka's disease, which is typical of achalasia, but happens epidemically in South America due to Trypanosoma cruzi. Now, if we get back to this photo, to this upper GI endoscopy here, that was for cancer. Now, if this patient has achalasia, what you find, you will not see a tumor like that. You will see an area which is collapsed or constricted. Collapse, or I will answer your question, but let me finish this. So this area, instead of having this tumor causing the obstruction, here the area is collapsed. Collapse why? Collapse because of loss of the Auerbach plexus. This area cannot dilate actually because of the loss of the Auerbach plexus. So what do you think now? If this area is constricted, what do you think is easier for the patient to swallow? Solid or fluid?
Solid.
Solid.
If the area is constricted and you want to swallow fluid or solid, which one will be easy?
Fluid.
But I think for solid it will be easier than fluid, no? Because solid can push, no? Solid food can push, but fluid cannot push, you know? Fluid cannot push, yes. So very characteristically, and in contrast, yes, in contrast to esophageal cancer, the patient who have got achalasia, the dysphagia start characteristically first for fluid, and this is the contrary actually to esophageal cancer. Okay, so this is one of the most important clinical features to allow you to differentiate between esophageal cancer and achalasia is whether the dysphagia started for fluid or for fluid or for solid diet. In case of esophageal cancer, dysphagia starts first for solid, and in case of achalasia, dysphagia starts first for fluid. Okay, this is how can you clinically differentiate between achalasia and dysphagia. Okay. Other causes include strictures, and here we have got peptic stricture, and this happens as part of GERD. This happens as part of GERD. So you may ask the patient about the history of indigestion, history of heartburn, history of retrosternal pain. All this can go with GERD. And this is known as peptic stricture due to destruction of the lower part of the esophagus by means of acid reflux. It can happen also due to ingestion of corrosives, and this happens usually in children when they ingest these destructive or injurious materials. Okay. Esophagitis, usually this happens either due to viral infection like herpes zoster simplex, and commonly it happens secondary to candidiasis, particularly in immunocompromised patients. Okay, so immunocompromised patients are prone to candidiasis and herpes zoster infection of the esophagus, and with this esophagitis you can get dysphagia. So you should ask about these features and whether the patient is immunocompromised or not as part of your clinical evaluation. Okay. So now I have talked about the clinical features of the most important causes of dysphagia, whether esophageal or pharyngeal. I will just finish by summarizing how do you approach the patient clinically. Okay, so clinical evaluation involves two parts: history and physical examination. Regarding the history, first of all, may I ask you this question just to be sure that you are following with me? Anyone of you can summarize how do you take history from those patients? In 1 minute, please, Ya Faisal. In 1 minute, please.
Yes, I will ask the patient about the onset. Does it acute or chronic? And the nature of the progression. Does it the same level or not? If he is smoking, if there is any familiar diseases. If he is have any chronic illness, and that's it. If he's had a problem with swallowing liquid or solid food.
Yes, yes. Just you just need to recognize that these points. That first of all, we need to know what is the cause of dysphagia. Then try to find out whether the dysphagia is esophageal or pharyngeal, because there are 30 causes for each one of these two categories. Okay, and then you ask about the onset of dysphagia. How did it start? How did it progress? Whether quickly or suddenly or gradually or insidiously, and then try to find out whether dysphagia, the pattern of dysphagia, whether it was for solid or for fluid phase, okay? And then try to find out the other factors, predisposing factors, for example, if the patient is suspected to have, for example, a cancer, travel history, for example, if you travel to South America, any family history, and other predisposing fact, if the patient lost weight or did not lost weight as part of the cachexia and so on. Okay, so the onset, the nature, progression of dysphagia, associated features. If the patient, for example, what do I mean by associated features? I mean repeated chest infections, for example, sore throat, hoarseness of voice. Okay, this will give you a clue about the underlying cause, and of course, halitosis, rumination. This points to a pharyngeal pouch. Okay, and then the physical examination. Again, I need one of you just to summarize what do you expect to find on physical examination. Who can summarize, please? What do you? Yes.
Maybe neck mass.
First of all, generally the patient will be what? Cachexic, no? If he has cancer, no? So try to find whether the patient is emaciated or not emaciated. I mean, did he lose weight or not? Yes. What else?
Maybe in that syndrome, that iron deficiency anemia, if there is a paler person or
yes. So looking to the eyes, we look for pallor, and what else in relation to this patient? Pallor and jaundice, no? Pallor and jaundice, because he could be having a tumor, and the tumor is causing what? Metastasis. Okay. Yes. What else as part of physical examination? Examining the left supraclavicular fossa, looking for what? For this virtue. Yes, virtue lymph node. Don't forget, you have to palpate in the left supraclavicular fossa for this lymph node, which is known as a sign. The name of this sign is Crozier sign. Examination of the abdomen. If the patient have got metastasis into the liver, you can get what? Hepatomegaly. You can get hepatomegaly. Examination of the chest. If the patient have got pleural lung metastasis and he has, for example, pleural effusion, you can also find signs as part of the chest. Okay, so this is how do you approach those patients clinically, and this lecture is actually about the clinical features, the clinical presentation of dysphagia. At other levels of the curriculum, we will talk about the details of investigations and management. Yes. So if you have any question, please do point to me before we leave to the next session. And meanwhile, please raise your hand, please, for attendance. Raise your hand for attendance, please. Yes. Any questions, please? Any questions? Yes, Abdulaziz. Abdulaziz.
الدكتور رفعت يدي علشان التحضير بس.
اوكي. طيب يا شباب، any question يا شباب؟ any question؟
في question دكتور.
Yes.
في الشات.
Yes, ask me.
في سؤال في الشات اللي هو سؤال بندر السلطان، يقول له what is vigorous achalasia?
Yes, vigorous achalasia. This is a type of achalasia. Achalasia is painless. Dysphagia is painless. But when the disease is advanced, you get gross dilatation of the esophagus, and this gross dilatation results into reflex contraction of the esophageal muscle. Reflex contraction of this muscle, which can result into pain. into pain. So vigorous achalasia is achalasia associated with what? Associated with pain. Vigorous achalasia is achalasia associated with pain. This pain is not due to peristalsis. This pain is due to reflex contraction of the esophageal muscle due to gross dilatation by foot. Okay, is that clear? Is that clear?
Yes, for me.
Yes. So achalasia
clear.
is achalasia. Yes, achalasia characterized by pain. Characterized by pain. Any other questions? Okay. If there are if no more questions, I will leave you know. I will let you know go to join the other session, please.
دكتور
Thank you.
I will دكتور انا بس عندي شيء دكتور اخر محاضره عندنا يوم الثلاثاء اخر المحاضره نفس كذا انا رحت طلعت الله يكرمك دورة مياه ورجعت لقيتهم رافعين ايديهم على نهايه المحاضره رفعت ايدي بس انك طلعت انت على طول
يعني الدكتور سجلك حاضر ولا غايب؟
ما ادري عنك والله دكتور انا اخر شيء رفعت ايدي مع الطلاب بس ما اتوقع انك سجلتني لانك طلعت
في محاضرتي انا
اي نعم في محاضرتك.
واسمك مين انت؟
معاذ التميمي.
خلاص I will check it يا معاذ ان شاء الله. I will check it. I will see.
ان شاء الله.
السلام عليكم ورحمه الله وبركاته.
السلام عليكم.